I will tell you about how we manage a case of parapharyngeal mass. It's very important to know the location, boundaries, contents, the compartments about parapharyngeal space to have a better understanding about the disease. So we'll start with that. These are the tonsils, and you have a real picture also, a photograph also, tonsils and the tongue. The space behind the tongue, the posterior part of which is occupied by the posterior part of the tongue, and it starts from the posterior part of the tongue, is the oropharynx. So this pharynx, it can be nasopharynx, oropharynx, or laryngopharynx. So the space behind the pharynx is called retro, and by the side is called parapharynx. So now we are going to discuss about parapharyngeal space. See this picture, you have a tonsil here, and the space here is the parapharyngeal space. Okay. Now, what I am going to do here is, I am going to rotate this picture like this. Now, this is a tonsil, tongue, uvula, and this is the space, right? Now, see the next picture here. So this is the tonsil, and this space is the parapharyngeal space. So here you have a styloid process. So the compartment in front of the styloid process is called pre-styloid compartment, and the compartment behind the styloid process is called as post-styloid compartment. So coming to the boundaries of the parapharyngeal space, if you see anteriorly you have the interpterygoid fascia. These are the pterygoid muscles. You have the pterygoid interpterygoid fascia, and posteriorly you have the deep layer. Here you will have the deep layer. So this whole area is the parapharyngeal space. So the pre-styloid compartment, the contents of the pre-styloid compartment, you'll find fat, loose areolar tissue, few lymph nodes, and internal maxillary artery. All the important structures are seen in the post-styloid compartment, which comprises about carotid artery, internal jugular vein, then you have the sympathetic chain, the important lower cranial nerves 9, 10, 11, and 12. So these are the contents of pre-styloid and post-styloid compartment. Now, the presentation of pre-styloid and post-styloid compartment is different when you have any mass here. I'll show you a picture. So, if you have a mass in the pre-styloid compartment, it will push the tonsils medially, like how it is shown in this one. It will push the tonsils medially. Same way, there will be a bulge in the neck also. If it is post-styloid compartment, here the tonsils will be normal. There will be a bulge behind the tonsils. Likewise, there will be a swelling in the neck also. Now, what are the common reasons for parapharyngeal space mass? It can be developmental. I'm just naming a few, like branchial cyst, lipoma, lymphoma, vagal neuruloma, schwannoma, hemangioma, or parotid gland malignancy, and the commonest being metastatic lymph nodes. These are the common reasons for a mass in the parapharyngeal space. Now coming to the presentation. To start with, the patient will have throat irritation, and it may progress to difficulty in swallowing. At the same time, they start developing neck swelling also. So, not only this, if suppose the patient is neglected at this stage and there's a progress in the disease, in that case, they can have one-sided hearing loss, and if the lower cranial nerves are involved, depending about the cranial nerves, they may have tongue deviation if the 12th cranial nerve is involved, shoulder weakness if the 11th cranial nerve is involved, and change of voice in case of the 10th cranial nerve is involved. See this patient, let me present you one case where this patient presented to me with a neck swelling and slight throat irritation also. So let me remind you at this point that if it is pre-styloid compartment, the tonsil is pushed medially, and if it is post-styloid compartment, the tonsils will be normal. There is a bulge behind the tonsils. This is the main difference. So this patient, on examination, there was a swelling in the upper part of the neck. The skin over the swelling was normal. It was not fixed also. Swelling was firm in consistency, edges were well defined and mobile too. And the carotid pulsation was normal. And on examination during her first visit, it was noted that she had sore throat and the tonsils were enlarged and pushed medially. But it was not at all, not much of, it was not quinsy for sure. So a course of antibiotic was given. She was reviewed within 5 days. And the neck swelling persisted. So we went ahead and did CBC, ESR and C-reactive protein, and the slight rise in CBC and significant elevation of ESR. So we went ahead and did the ultrasonography, and we did a fine needle aspiration too. CT scan was taken, which showed a significant mass sitting in the parapharyngeal space. Now, so as per the report, we decided that we'll go ahead with surgery. So patient was admitted, consent taken, anesthetist saw the patient and cleared for surgery after physician and cardiology clearance. And that night, 12 o'clock onwards, she was restricted she was asked to be nil per oral from midnight. Next day morning was the surgery, and we explained the complications of surgery too. The complications are bleeding, breathing difficulty in case the bleeding is significant. There's a possibility of infection and cranial nerve damage. As mentioned earlier, there are 4 important cranial nerves. So there is a high possibility that the cranial nerve damage may be there. So that we have also explained. Now, we started with the incision and layer by layer opened up and reached the parapharyngeal space, and the whole mass was taken out in one single piece. And it was sent for biopsy. It was reported as vagal schwannoma. Post-operatively, the surgery took about 1.5 hours. Post-operatively, the patient was shifted to ICU, kept in propped up position. IV fluids were going on, and all the vitals were monitored. Antibiotics and analgesics on, and we have put a pressure bandage too. Subsequent day, next day morning, I removed the glove drain which I had placed, which hardly takes less than a minute, and it is not painful. There is no complications, and the patient was discharged the next day itself, the second day itself. She was discharged with antibiotic, painkiller and vitamins, and advised to do in a local hospital wherever nearby she can get the wound dressing done every 3rd day and 5th day, and reviewed to us on the 7th day for suture removal and biopsy report. She reviewed on the 5th day, so we did wound dressing and changed the dressing. And this 7 days of waiting, she has to be on balanced diet and she has to be ambulant at home, do all the necessary basic work at home, and advised to drink plenty of water, to avoid hot and spicy food and cold drinks, and not to overextend the neck, and to review on the 7th day. In case the patient has got any of the following complaints, then she has to report immediately. These are fever, severe neck pain, pin pricking sensation in the neck in the area where we have operated, occasional bleeding from the ear, or severe irritative cough. These are the red flags. So in this case, she has to report back immediately, and she should not be waiting for the 7 days. So 7th day she came back, sutures removed, report shown to her, and she was on regular follow-up. That's it. So that's how we manage a case of parapharyngeal mass. Thank you so much.